Hey, good afternoon. Thank you all for joining. So let's get started. We will talk about the basics of shoulder replacement today. I will not show you big operative images, and then I will not show you all the clinical outcomes, etc., etc. I will just apprise you about the basics of a shoulder replacement as to what exactly is a shoulder replacement, how many types of replacement, and then what are the outcomes. So these are the things that we are going to touch in today: relevant anatomy, the indications for each type of replacement, the types of replacements, and their outcomes. So anatomy, what I would like to emphasize here is two things. One are two groups of muscle. One is the deltoid, the other is the rotator cuff, obviously comprising of subscapularis, and infraspinatus, and teres minor. And this particular diagram here is probably important. We will be revisiting it probably 3 or 4 times during this webinar. The center of rotation. So if you see the center of rotation of the shoulder, it is somewhere along the axis of the humerus. It is somewhere here, away from the glenoid. And why the center of rotation is important? Because the red line shown here is the lever arm. That is the one which aids our rotations and our forward elevation, etc., etc., of the shoulder. So I would like you to have a look at this diagram. If you see the right, this is the proximal humerus, and then the arrow marks actually represent the force of pull of different rotator cuff muscles, and then obviously of the deltoid also. So this is what makes the shoulder to function the way it does. The deltoid actually pulls the head of the humerus away from the glenoid, and then the rotator cuff actually counteracts the force the deltoid applies and depresses the humeral head, and that is how the humeral head stays within the glenoid. The glenoid is a very small articular surface. For the humerus to stay within the glenoid requires the balancing of the muscles which act on it, mean the deltoid as well as the rotator cuff muscles. And the other thing we need to remember when we make a choice of what kind of replacement to do, and then whether to replace the shoulder or not, is the glenoid inversion, the glenoid inclination, as well as the version. The picture on the left shows the version of the glenoid. If you see here, what is version? Version is the angle between the axis of the glenoid, this one, and another perpendicular drawn to that. So this is the glenoid version, and it's normally about minus 10 degrees, that is 10 degrees of retroversion. As you can see here, this is the anterior side, this is the posterior side, and the glenoid articular surface is obviously facing posteriorly. So it is about 10 degrees, it is in about 10 degrees of retroversion. And then the picture on the right depicts our inclination, and as you see, this is the angle of inclination, the angle between the tangential line to the glenoid and the perpendicular. And then this is the angle of inclination. The angle of inclination is about 10 degrees superior. That means the glenoid articular surface is facing 10 degrees upwards. So this is something that we need to remember to make our choice of replacement and to reproduce the anatomy when we are replacing the shoulder. And then this one here, as you can see here, this is called as the offset. So if I draw the midline of the medullary axis of the glenoid, it somewhere exists just medial to and posterior to the center, but it is not actually in the center. The distance between the center and this axis is known as the offset, and it is usually offset by about a centimeter, half centimeter to a centimeter. Right. So indications or types. There are shoulder is a very versatile joint. It is not like the hip or the knee. The knee, obviously, we have only one type of knee replacement and a partial replacement. Hip obviously we have a Hemiarthroplasty and total hip arthroplasty, and sometimes hip resurfacing as well. But shoulder, one, it is very versatile. The function of a shoulder is again very versatile. We need our shoulder to lift, to comb our hair, for hygienic purposes, to throw. Some people will come and demand, I need to play golf. Another person will come and say, I need to play a throwing sport, etc., etc. So, and obviously we need to match their expectations, and then and hence because of the expectation as well as because of the versatility in its movement and its anatomy, we have different type of replacements. One is shoulder resurfacing, the other is hemiarthroplasty, the anatomical shoulder replacement or the anatomical total shoulder replacement, and the reverse total shoulder replacement. And we will talk about it taking example of each type. So if you have a look at this X-ray, this X-ray belongs to a 30-year-old engineer, steroid dependent, probably, if I remember well, because of his asthma, and he's been experiencing pain in his shoulder for 2 years. And then initial X-rays taken were obviously normal because we can't make out an avascular necrosis in the initial X-rays. So after 2 years, we did another X-ray and we found this. If you have a look at the X-ray, the glenoid looks fairly normal. The articular surface is maintained, the articular congruity of the glenoid is maintained. It's just the humeral articular surface that is affected. Even with the humeral articular surface, you can see here, it's only the articular surface that is affected. The tuberosities, the subchondral bone, everything seems to be intact. And the same was confirmed on the MRI. You can see the glenoid articular surface is normal. It's only the humeral articular surface that is affected, obviously with a few subchondral fractures. But the bone stock per se was normal. So if you go back and see, this is a 30-year-old guy. You can't say that you restrict your movement or we will give you a total shoulder replacement. Obviously, you can't play sport with it, you can't throw, you can't lift anything heavy with the total shoulder replacement. Obviously, it won't suit him. He is not the one we can offer a shoulder replacement or a reverse shoulder replacement for. So obviously, if you see what are his options, either leave him alone, tell him, okay, you continue with what you have, you'll continue to have pain, you can take pain medications, give him some injections like cortisone for temporary relief. And obviously, some people talk about stem cells these days, especially for things like avascular necrosis. Obviously, for me, stem cells, I don't use it in the joint, and in India, stem cells is still not legal, and we're not licensed to use stem cells. So the option for this guy is something called shoulder resurfacing. So what I have done here is I have not done anything to the glenoid because his glenoid articular surface was quite normal. All I did was to dislocate his shoulder joint and then freshen up the humeral articular surface, as you can see here in this picture, and then insert the prosthesis. So obviously this prosthesis matches the diameter of the native humeral surface, and then it has a peg which goes into the subchondral bone, which aids bone ingrowth into the peg, and then which holds it very firmly without any movement. So all I have done here is to replace his articular surface. I have not disturbed the anatomy. I have not disturbed the rotator cuff. I have not disturbed the deltoid. I have not disturbed the articular surface. The articular surface remains the same. The anatomy remains the same, except that the deceased articular surface was replaced by a metal. And this is called shoulder resurfacing. The advantages of this being, you can allow him to participate in sport. You can allow him to lift heavy things. And he more or less, he will continue to have a normal shoulder, except for some clicks here and there, which are obviously pain-free. So sometimes there are patients who come, we will be thinking young patients with a little bit of glenoid being affected. The articular surface of the glenoid shows early arthritic features. What can we do? The answer is something called a Riemann Run Procedure. So what we do, we go and ream the glenoid. Reaming in the sense we freshen the articular surface. When the articular surface is fresh, what we do is it aids growth of fibrocartilage. Obviously not hyaline cartilage. It aids growth of fibrocartilage. so that the articular surface becomes smooth for a metal surface of the humerus to work on it. So this is one of the options. The second option is a meniscal allograft. So we take an allograft of the meniscus, we insert anchors into it and fix it on the surface of the glenoid. By that, what we are doing is we are converting a rough articular surface into a smooth articular surface, and which again improves the pain and improves mobility of a glenoid resurfacing. And then the next type is hemiarthroplasty, which is mostly reserved for fractures of the proximal humerus. We usually the first option or the first thought of any humerus fractures is to fix it, but sometimes there are fractures where the outcome after fixing it is very bad, so we tend to do a replacement in those fractures, especially in patients with proximal humerus fractures, which are four-part fractures of the humeral head where the articular surface is involved, and those with poor bone stock. And then, obviously in hemiarthroplasty, why I'm talking about hemiarthroplasty is for this reason. The tuberosities, when I consider doing a hemiarthroplasty, the first prerequisite is I should know that I can get the tuberosities to heal and to function further, because the tuberosities will contain the attachment of the rotator cuff muscles, and only when the rotator cuff muscles work, the hemiarthroplasty will perform. So if you have a look at this fracture, this was a 60-year-old male, came to us after 2 weeks of the injury. This is the X-ray which shows a dislocated humeral head, and then both the tuberosities are obviously fractured, and then you can see the bone stock is not very good. And then we took a CT. You can see here there is an unreduced posterior dislocation along with, this is the lesser tuberosity lying here and the greater tuberosity here. The glenoid obviously was unaffected. I knew that the lesser tuberosity will have the attachment of subscapularis, and the greater tuberosity here will have the attachment of the other rotator cuff muscles intact. So we offered the patient to go through a hemiarthroplasty. Obviously, as I said, the points to note here is, one, it's a comminuted fracture, it's a dislocated head. So once the head is dislocated, the vascularity remains doubtful, even if I get it back and fix it and the fracture heals, there's every chance the patient will go in for avascular necrosis and further arthritis. And I knew that the tuberosities were intact, so the hemiarthroplasty was a good decision. These are the intra-op pictures you can see here. I have tagged in, this is the greater tuberosity, this is the lesser tuberosity, this is the shaft, and then you can see here the prosthesis sits well on the shaft. And then this step is very important, because this is where the tuberosity sits in, and then we measure the length of the opposite shoulder from the top of the prosthesis to the metaphyseal region, and then we try to recreate the height, because we don't recreate the height and this prosthesis tends to sit in proud, he runs the chance of having an impingement in future. So we try to get this as accurate as possible, and obviously tie the tuberosities onto this. And then the advantages of this obviously is that you don't need any immobilization. You can start moving the shoulder immediately, and then the chance of arthroplasty is very less. And then I have, as you can see here, this is a cemented stem. I've also made sure that the prosthesis which is outside the shaft is free of any cement, because cement can interfere with healing of the tuberosities. So this is just a pictorial representation. Obviously, this is a cadaveric picture illustrating how we tie the tuberosities. So this is the prosthesis. We actually wrap the lesser tuberosity and the greater tuberosity on the prosthesis and make sure that we tie it very tight, and then we get to heal them onto the shaft as well as onto each other, so that they can perform well. Remember, the prerequisite for any shoulder prosthesis to perform well is an intact rotator cuff. So obviously, to make sure the cuff performs well and the tuberosity heals, We use different technique. One of them is the hydroxyapatite coated stem, which helps in bone ingrowth. The other is the pattern of fixation. As I showed you in the previous slide, we make sure we wrap the tuberosities on top of the stem, and then we tie it. We have a fixed pattern for doing that, and then that gives a very strong fixation. We can even start movements of the shoulder immediately. The other thing is bone grafting. Obviously, we would have taken out the humeral head. The humeral head is rich in cancellous bone. We scoop it out and place it between the tuberosities and the stem, and between the tuberosities and the shaft, so that it heals the tuberosities well for a good future shoulder arthroplasty. For a good performing hemiarthroplasty. So the third one is a total shoulder. This is more or less, I would equate it to a total hip replacement. As you can see, this is a 60-year-old patient with a primary osteoarthritis of the shoulder. I don't remember the sex of the patient. The patient had pain affecting his activities of daily living, restricted sleep. Obviously, the patient had failed conservative management like injections and physiotherapy. The answer is fairly simple. As you can see in the picture, both the glenoid as well as the humerus were arthritic. The joint space was very narrow. They were almost touching each other. The choice, old patient, primary osteoarthritis, both the joint surfaces involved, is pretty straightforward. The patient underwent total shoulder arthroplasty. As you can see here, this is a primary total shoulder arthroplasty. It has a humeral component and a glenoid component. You can see here that the articular surface is restored. Here, there was no space at all. Now the articular surface as well as the space is restored. Obviously, that means there is a polyethylene component here. So a lot of us are not very familiar with total shoulders. So I thought I'll dissect out and show you the components of a total shoulder. This is the glenoid component, obviously. It has pegs. This particular design has pegs which goes and fixes onto the glenoid. This is the humeral head, which is a metal bearing. So this is a metal on a poly bearing. And then this is the stem which goes into the humeral canal. So the stem is obviously of two types. One is the cemented, the other is the cementless. We tend to decide which one to go for depending on the age of the patient as well as the bone stock. Obviously, a patient with good bone stock, relatively young, gets a cementless. A patient with bad bone stock, relatively old, gets a cemented total shoulder arthroplasty. And this one here is a close-up view of the humeral head. You can see here it has numbers 3, 12, 9 and 6 obviously. This one is to adjust the offset. If you remember the offset, I told you that the center of the humeral head is not in line with the medullary canal. So this is the medullary canal. This is the center of the humeral head. So when we insert the prosthesis, we obviously do a trial. We dial the trial on the humeral metaphyseal surface like this, and then you know which one matches it better. We try to get a good cover on the humeral metaphysis. So this is to basically trial, and the real prosthesis also has the same markings, and then we get it to seat the prosthesis. You can see here, this is not in the center. This one is narrow, whereas this one is wide. So how we decide this is based on the trial, based on these numbers. We get it to sit like this and then insert it into the canal. And that's how the prosthesis functions very well. So obviously, it did have an evolution. Looking at this glenoid component here, this is what we commonly use these days. It is a peg glenoid, and this is made up of a single component. It has 3 or 4 pegs and a central peg, which we insert after cementation. But that was not the case before. The world started off with something like this. They started using a keel device, a keeled glenoid component, which was like this to start with. And then they inserted the keel, the surgery went on well. And after a year or so, they get the x-rays done and they could see to their surprise that the humerus was completely osteolized and, sorry, not the humerus, the glenoid was completely osteolized and destroyed, with the prosthesis obviously very loose in here. So they went back and analyzed, and they tried finding out the reason for this. They found something called a rocking horse effect. So as you see, the rocking horse rocks like that, and then with the humerus also, it rocks on the glenoid. It does not have a smooth movement like that. It actually has that movement also, a little bit of rocking movement, and that is why they noticed that the keeled glenoid started to fail. Because of the uneven distribution of forces, the edges started to become loose, and then the keeled glenoid ultimately failed. And then they started finding answers, and the second generation of the implant started to emerge. So this is something that we use very commonly these days, a pegged glenoid, which has a central bigger peg and then 3 peripheral small pegs inserted after cementation. And some people said, oh look, we don't like to use cement, is there something better? So we started having this uncemented pegged glenoid. As you can see here, this is hydroxyapatite coated, and then these are all HA coated as well, which imbibed bone ingrowth. But the criticism for this is that the thickness of this when compared to a knee joint is very small. This is hardly, 2 put together is about 3 to 4 millimeters, and then it started to fail very quickly when compared to these type of glenoid. And then people started to use screws instead of these pegs to counteract that. And you can see here the articular surface of this glenoid is uneven to counteract the rocking horse movement. However, people are still not happy. The results are not very good with this one and this one. So we're more or less using this one very commonly these days, the pegged glenoid with 1 big one and 3 little pegs. Very recently, about 2-3 years ago, this was introduced in the market, the 3rd generation ones. As you can see here, this is something called tantalum. Tantalum is something that attracts bone. So they grit blast it, and then they coat the surface of the glenoid like pegs with tantalum. And when they do that, the bones obviously, the tantalum, the main property of tantalum is to attract bone. So what it does when we insert it into the glenoid, it does not allow before it becomes loose, it allows a lot of bone ingrowth, and it helps the prosthesis to stabilize on the glenoid, thus reducing the chance of loosening. Obviously, then again, as I said, for a total shoulder, let's recall this picture again. The balance of the deltoid as well as the rotator cuff is very important. So it's very important to have an intact cuff or a repairable cuff. So otherwise what happens? This happens. So you can see that this shoulder has failed because the rotator cuff was not intact and the surgeon did this. So there is a superior migration of the head, and then such a shoulder always fails. So in these cases, as you can see here, this was a 75-year-old male, had rotator cuff arthropathy. You can see here the patient has no rotator cuff, all rotator cuff muscle atrophy, the superior migration of the head. As you can see here, this prosthesis and this X-ray is more or less similar. The head is migrated superiorly. These patients will have pseudo paralysis. You ask them to move their shoulder, they start shrugging their shoulder, and then they actually have an irreparable cuff there. And in these patients, so this was the arthroscopic image of that patient. That patient was bent on getting his cuff repaired. So I went in and tried repairing it, which was impossible. So you can see there's no cuff literally. And then this patient ultimately ended up getting a reverse shoulder replacement. Again, to tell you more about reverse shoulder, again, let's go back to our picture. The shoulder functions well because the deltoid and the cuff is contracted well. And then this is the center of rotation. So if the rotator cuff is not working, what happens? The deltoid tends to pull the shoulder upwards, but there's no one to counteract that. So in reverse shoulder, what we do is we transfer the center of rotation medially so that the lever arm increases. You can see here, the length of the lever arm in a normal shoulder is this much. The reverse shoulder is this much. So the lever arm has increased. And then you can see the fulcrum length also has increased. This makes sure the deltoid takes over the function of the rotator cuff, and then we don't need the rotator cuff anymore. So that is the advantage of reverse shoulder. So obviously Gramont, a French scientist, designed it in late 1980s, and this is how the design was. And obviously after 3-4 years started to fail. Why? Because not because of the rocking horse effect. This is something called notching that happens in a reverse shoulder. What happens is that this part comes and notches onto the scapula, as you can see here. This starts and comes every time the patient depresses the shoulder, it started to notch on the scapula, causing loosening of the prosthesis. So obviously people started improving on the prosthesis, and then they came up with this. So this one has as you can see here, a little cap here, or a little extension of the prosthesis which covers the glenoid, the inferior surface of the glenoid, so that there's no notching. And this is more or less our modern day reverse shoulder, which has a base plate. This is called a base plate, which has different, it has a central plug and 4 different screws. Obviously changes with the manufacturer. And then this is called a glenosphere, which has different sizes to adjust the tension on the deltoid. This is the poly, and this is the humeral component. Obviously it has 2 components. One is the stem, and this one is the metaphyseal component. And this little holes you see here, if in case the tuberosities are intact, like in a malunited fracture, we tend to incorporate it into this, so that the patient does get some element of rotation and not only elevation. So the other indications obviously of a reverse shoulder is fractures with arthritic glenoids, malunited fractures, unreduced dislocation wherein the cartilage is already lost. And then obviously the contraindication is a non-functioning glenoid. I personally do a nerve conduction study of the deltoid and make sure the deltoid is functioning well before I plan or before I offer the patient reverse shoulder arthroplasty. So obviously we came to know that the placement of the prosthesis is very important with either the total shoulder or the reverse shoulder. So now the world has started to improve on how to place the shoulder. So now we've got good components, we've got good results, but we need to make sure the placement of the prosthesis is perfect. So what we started doing is to planning it pre-operatively. So this is a computer image where I can obviously plan where to place my glenosphere, where to insert my pegs, where is the axis of the glenoid, etc., etc., how much inclination to give, how much retroversion to give. And then I can send it off. These are all CT based, obviously. I can plan this and send it off for approval. And then the company designs jigs which are specific to the patient, and which goes and gets clipped onto the surface, and through which I can insert my prosthesis that makes the prosthesis fits in more accurately. This is like an improved version of our computer navigation because there's not much space on the shoulder to do all the navigations. Obviously we did navigations and the results were not very good, so we started to do this patient specific instrumentation, which have showed encouraging results so far. And I am very proud to say that I was a part of the first series of a patient-specific implant. You can see here that we could reproduce the intraoperative planning post-operatively close to 0.5 to 1 degrees. Obviously, we've been doing more and more of these, and we are trying to get better with this. And then as we end the talk, I would like to just show you this table, how we select the type of prosthesis that we put in. Obviously, age is a consideration, the subchondral bone, and the most important is the rotator cuff. So if it's a young patient, intact subchondral bone, intact cuff, so we try to do a resurfacing. Old patient, without any consideration to the subchondral bone, with an intact cuff, but with an intact glenoid, we do a hemiarthroplasty. And then, as I said before, old age, without any consideration to the subchondral bone, non-intact rotator cuff, primary osteoarthritis, we do an anatomical shoulder, whereas when the rotator cuff is not intact, we tend to do a reverse shoulder. Thanks for your patient hearing.